This is a case report of a 2-lead MRI-guided laser ablation for a seizure focus done in the lateral position. As an introduction, approximately 7 to 10% of adolescent epilepsy patients will have drug-refractory epilepsy. For this population, MRI-guided stereotactic laser interstitial thermal therapy, or MRG-LITT, is a minimally invasive option. In the general population, approximately 80% of epilepsy patients achieve seizure freedom following MRG-LITT, and this treatment modality demonstrates efficacy and safety in the pediatric and adolescent populations. For lesions that are not amenable to open approaches, such as periventricular lesions, this approach can be used. This case is a 25-year-old right-handed male with intellectual disability, structural brain abnormalities, and focal epilepsy with seizures starting at 14. He was seizure-free on oxcarbazepine from 16 to 19, however, he has been refractory since then. MRI revealed polymicrogyria involving the bilateral parietal occipital regions, and MR fingerprinting demonstrated that the nodules and cortical malformations on the left parietal occipital area seem to have higher T1 and T2 signaling compared to the right side. This slide illustrates the areas of gray matter heterotopia involving the left lateral ventricle. Subsequent diffusion tensor imaging revealed that the left polymicrogyria and the left lateral temporal lobe share a common connection. An SEEG shows that 2 GTCs and 1 focal unaware seizure originated from the left anterior temporobasal electrode. The plan, therefore, was to do a laser ablation of the left polymicrogyria with the outflow tract. This slide illustrates the overview of the key steps done at our institution. Following volumetric imaging and trajectory planning, we used the O-arm in order to verify the trajectories and also measure the thickness of the skull. The operative setup is completed, followed by drilling and durotomy, and then the bone anchor is inserted. Of note, this case used 2 bone anchors for 2-lead MRG-LITT. After bone anchor insertion, the leads are inserted into the bone anchors and secured into place. Following that, the MRG-LITT can begin after the patient is transported to MRI. This slide illustrates the O-arm setup and the patient in the lateral position. The O-arm parameters are on the bottom right-hand corner of the slide. The O-arm is then used to verify the trajectory. As seen here, a staple on the left side of the patient's head is used to test the trajectory of the robot. Following trajectory verification, the operative setup can begin. The patient's head is minimally shaved, and the incisions are marked on the scalp. The robot is prepped and draped, and then the robot is guided to the appropriate trajectory. The first port is inserted into the trajectory corresponding to the left lateral polymicrogyria. A drill stop distance of 96.9 was calculated based off of O-arm and volumetric data. The second port was inserted into the left medial polymicrogyria with a drill stop distance of 102.5. Of note, in order to achieve a bolt distance of 15 millimeters, the bolt wings had to be shaved prior to insertion, with a final fixation distance of 50 millimeters from the scalp. After bolt insertion, the leads are then inserted into the bolts and fixed into place. The patient is then transported to MRI, and the MRI imaging here demonstrates the lateral and the medial leads placed into their respective targets. This slide illustrates the heat map as well as the final MRI map of the left lateral polymicrogyria laser ablation. Of note, the left lateral polymicrogyria was ablated in 3 sessions consisting of 2 minutes of laser pulsation each. Between each session, the lead was advanced towards the subsequent target, as seen here on the heat map. Similarly, the left medial polymicrogyria was ablated in 3 sessions of 2 minutes each, with a final map shown here. Postoperative scan demonstrates no acute hemorrhage as well as laser-related tissue changes along the left lateral ventricle. MRI confirms that approximately 13.8 cc's of tissue were ablated. The patient did well in the hospital and was discharged on post-op day 1 on home seizure meds following a steroid taper. Some key take-home points for this case. MRG-LATT allows for selective ablation of periventricular lesions. This case further demonstrates the safety and efficacy of this treatment modality in the pediatric and adolescent epilepsy population. This was the first case to actually report the MRG-LATT done with 2 leads in the lateral position. And of note, a 2-port system was used in order to increase the amount of tissue ablated. In order to accomplish the appropriate distance between the 2 bolts, the bone anchors had to be shaved down in order to be placed close to one another. And that concludes this case. Thank you.